Good evening, everyone, and thank you for tuning in. I'm Frank with Cytometrics. It's my great pleasure to welcome you to our first webinar of the year. The webinar will deal with the interconnectedness of hormone and pain, fascinating topic. Our speaker is a naturopathic doctor from Victoria in beautiful British Columbia. In her practice, Dr. Gary has a focus on pain management as well as hormone health, and a special emphasis on how the two are interlinked and interconnected. If you have any questions, please type them in the Q&A box, and at the end of the presentation, Dr. Gary will answer those. It's now my great pleasure to welcome Dr. Adela Gary.
Thank you, Frank. Thanks everyone for joining us today. My name is Dr. Adela Gary, but most people call me Dr. Della, so please feel free to call me that. We will be discussing the connections between hormones and pain today, and thank you very much for Cytometrics for supporting us in this talk. And we'll get started here. So I grew up in Victoria, BC, as well as the surrounding area. I did my undergraduate degree at the University of Victoria, where I double majored in biology and psychology. And then I went straight into Boucher, where I graduated in 2015. I currently practice in Victoria at Pearl Healthcare, and I also practice online. And I have quite a bit of training in hormones and pain. So we're going to be able to put some information together today about those different areas, how they're interrelated, and some things that we can do when they are imbalanced. I live with my partner, Mike, and our Labradoodle, Fletcher. And we spend a lot of our time outdoors, baking, gardening, visiting family, and adventuring. In 2015, I was in a pretty bad car accident. I was in a rollover MVA on the highway on the island here. And I've dealt with some chronic pains since that accident. It gives me a bit of insights into some of the information that we will be discussing today. Luckily, nothing serious happened from the accident, but have had some chronic pain, including headaches. And I've had quite a bit of experience in dealing with headaches as a result. But one thing that helped me to feel a lot better was actually looking at my hormones and helping to balance out some areas that were lower, and progesterone at nighttime was definitely something that helped me to feel quite a bit better. So we'll talk about those areas and why that would be in some more detail here. My talk is also available on my website, just in case it's not in the Zoom chat area there, but otherwise we should have that available in a couple spots for you. So let's get right into pain here. We'll talk a little bit about why it occurs, make sure we're all on the same page here. So we'll start from the basics and work our way to some more complex scenarios. We'll discuss the symptoms, associated symptoms, reasons for pain, how we can diagnose pain. We'll talk about the basics of the sex hormones, inflammation, and then how they're all interrelated. We'll also discuss how this is related a bit to digestion and some other influencing factors that might increase pain, as well as hormonal dysregulation. We'll discuss the differences between males and females, talk about a case study, and then we will, of course, discuss treatments and therapies. So a couple of quick disclaimers. This lecture and the cited scientific literature, when referring to females and women, are referring to people that were born biologically female, and that's the same with males and men there. Please be sure to consult with a certified healthcare professional. I know most of you are naturopathic doctors, but just in case there's anyone else watching. And then there's no conflicts of interest in the research for this presentation, but it was sponsored by Cytometrics. So thank you very much to them. There will be some questions that I will ask, and you may answer those in the chat area of Zoom, just to spark some discussion and conversation during the talk. Questions, however, will generally be answered at the end of the talk. And if you have any questions specifically for me, please preface them with question for speaker or Dr. Della in the side there, and we'll be happy to answer those all for you. All right, let's get to it. So what is pain? As you'll probably mostly know, it is an unpleasant sensory or emotional experience, and it's typically associated with potential for actual or perceived tissue damage that is important to consider. We have specific receptors called nociceptors that in most cases will be sending information from an area that could be damaged to the spinal cord and then the brain. The brain will then distinguish information, decide what to do to it, and then send some signals back. And this could include voluntary withdrawal from a flame, or it could include some other information. Helps us to decide if something that we're exposed to is necessary to change. So if your hand is on a burner and you need to withdraw your hand, then it of course gives us some insights as to what we can do to make sure there's no future damage to those areas. It's definitely something we don't want to suppress right away because we do want to decide if it is important to know about. Pain helps us, and information that helps us to figure out what's going on with pain are things like the quality, the area it's occurring, the intensity, how long it's occurring, some things like that. And the degrees of pain is not always proportional with the stimuli itself. So when you are thinking about something being painful, you're expecting to be injected with something, or you're expecting something to happen to you that could be painful, typically will perceive it as being more painful than if you were not expecting the experience to happen. There's many types of pain that can be felt. It's quite confusing when you look at one category to another. So we'll discuss a few of these. So why pain? It gives us information so that we can decide if we do need to take further action. And this action could be, as I mentioned, voluntary or involuntary. So involve a reaction or deciding if we need to do something like shift our posture or move around in order to help us prevent pain from occurring. And for acute pain is something that typically lasts for 3 months or less. And then chronic pain is typically 6 months or more. And that area in between is subacute. There is some variation on the definitions of these, but that's what we find most widely in literature. How many of you are in chronic pain lasting 6 months or more? Please feel free to put that in the chat area there. Common types of chronic pain would be things like lower back, pelvic pain, headaches, sinus pain, eye strain, lots of different types. Types of pain include things like nerve-induced pain, neuropathies, so things that involve the nerves themselves. Psychogenic, so this would be more you're experiencing something in your life and your body perceives pain as a result of what's going on. We'll discuss this a little bit more. Musculoskeletal pain, abdominal pain, and then things that are more complex like central pain syndrome and complex regional pain syndrome. Symptoms and feelings of pain. So most of these are pretty common: aching, throbbing, burning, squeezing, stiffness, numbness, and tingling. But this is typically what you'd feel with acute going into chronic pain. And then there's other things that you can feel on top of that. So some of the associated symptoms you usually feel if it's more of a chronic pain are things like being tired or fatigued. This makes a lot of sense. Most people that are in chronic pain, pain itself, as we will discuss, is a very energy dependent resource. There's lots of different processes that are occurring when you're in pain. So over time, when you're feeling this for long periods of time, you're going to be more tired. I found this with the headaches that I was in a lot. We're just constantly working harder to make the body do what you want it to. And then often your mood is impacted by this as well. After the car accident, I couldn't move much for a few weeks. I was having difficulty with this. I was living alone at the time. I had support from family, but most of them weren't around me. I was living in Vancouver. Most of my family is on the island. And it's really easy to see how when you're in intense pain that a lot of things will spiral out of control, that you're going to have mood impacted, you gain weight really easily. This is going to impact a lot of areas of your life. And then when we have pain for longer periods of time, we often get caught in pain cycles. So the body becomes sensitized and we have a harder time being able to feel that pain is going away because the body is more sensitive and will react a lot quicker. There's quite a bit of research on chronic pain being associated with depression. And then we also see a lot of research on people that are depressed feeling more pain. So there's definitely a cyclical relationship between those two things. And someone raised their hands a couple of times. I'm just going to double check there. Nothing needs to happen. Just let me know if there's anything important that needs to happen there. So,
okay,
sorry, Frank?
Yes, I will let you know if there is
All right,
anything.
thank you.
Yeah.
So these two things definitely have quite a bit of research that they're both associated with one another. We see antidepressants used commonly for pain, and SSRIs I've seen used quite a bit for migraine specifically. So the symptoms of pain and the reasons for pain are really interlinked, and you can have more than one thing causing pain at the same time. What do you think the most common reasons for pain are? Please feel free to discuss this. When we look at things like inflammatory conditions, we'll go into some detail as why inflammation will create pain and why people who are in pain have more inflammation. Things like metabolic conditions, diabetes, something that we will discuss briefly, infections, autoimmune disorders. So the immune system is attacking healthy tissue, and this will often result in pain conditions. Trauma, so you sprain your ankle, you get burned by something. And cardiovascular, when you're having pain or tightness in the chest as a result of blood not flowing through properly. And digestive and organ conditions are a couple of other reasons. So diagnosing pain conditions, symptomology is really important to pay attention to. If you look at the previous slides, and then also doing things like a physical exam, you want to palpate the area that is feeling painful, move it around, see what makes it better or worse. We look at blood pressure, heart rate, some of the basic things just to make sure nothing obviously wrong is going on there. So for labs, there's quite a bit of lab work you can do. Definitely want to run some of the basic things. And I usually will always include blood sugar, especially if the patient hasn't had it done before or hasn't had it done in quite a while. Imaging is something else that would be quite helpful, sending people to specialists if needed. So for us, we will have to send to a GP to do the specialist referrals, but sometimes that is necessary. And then other types of screening like infection screening, so previous history of what's been in the body, looking at genetics, and stool testing is something else I've found to be quite helpful to rule out infection as a possible cause of inflammation in the body. And then clinical judgment. Clinical judgment is super important. We cannot look at or kind of outweigh that enough. Last time you were diagnosed with pain, were you diagnosed by any particular person? What was done to help you be diagnosed? What techniques were used, or were you even diagnosed? Is it something that was ever found out? When it comes to pain, there's a lot of mitigating factors, and lots of things will influence them. Hormones are definitely one of those, though. So let's get a little bit into the hormone side of things. So for sex hormones, they're quite complex. There's lots of different things to think about when we're talking about sex hormones. We have the four major types, which are testosterone, DHEA, progesterone, and estrogens. We typically want to know what these levels are doing if we're looking at inflammation, pain, different things. So usually we will want to test these before considering doing any types of treatment. Now, I don't have any affiliation with any test companies. I will be talking about one quite a bit, but it is one that I use a lot and I find very helpful. So hopefully some of you will too. But the best way to test sex hormones depends if the person is already on hormone replacement therapy or HRT. But a best way to get a comprehensive look at what's happening before a person is on HRT is by doing urine testing. The test that I like a lot that I use quite often in practice is Dutch Complete. This is by a company called Precision Analytical. What type of testing are you currently doing in your practice? The Dutch test allows us to look at the sex hormones, cortisol, some organic acids, as well as neurotransmitters. I'll talk about this a bit more. Saliva can be helpful, but there's actually quite a bit less research to find that supports doing saliva testing versus urine. Blood can be helpful for a lot of different things, but the hormones are much more liable and you can't get the same amount of information from blood as you would be able to get from urine, but definitely need to do it if we're doing things like looking at fertility, looking to see if someone is in a menopausal state, or if we're looking at something like the thyroid, then blood can be quite helpful too. Usually if someone is on hormone replacement therapy and we want to look at levels, then we'll do blood in combination with urine because both of them allow us to get more accuracy. So the Dutch test stands for Dried Urine Test for Comprehensive Hormones. This test includes the sex hormones as well as their metabolites. The metabolites are not typically something you're going to see on many other tests like saliva or blood. It has 4-point cortisol, but what's important to consider is the metabolites and the transitional products of cortisol. It allows us to find out information about how they're being transformed in the body, but how quickly they're being metabolized. So actually know how long cortisol is sticking around for and what kind of action it's having in the body. So if you're having a low amount of cortisol and it's being metabolized very slowly, you could have higher amounts of cortisol sticking around and have a better action from it. Versus if you have lower amounts and it's being metabolized really fast, then you're going to have barely any action from it in the body. So these types of things are important to consider. It also includes some measurements for organic acids, which we use as more accurate markers of vitamins. So B12, methylmalonic acid is in there, B6, we have markers for that, and then glutathione, which I found very helpful in terms of knowing which vitamins to support with when we're doing treatments for the hormone regulation. It also includes melatonin, creatinine, so we know if the kidneys are working properly when we're doing urine testing, and some markers for DNA damage and neurotransmitters. I've used many types of tests in my practice, but I always end up going back to this one. And the reason I do that is I've used tests that are more expensive, they provide more information, but clinically it doesn't end up changing what I do very much. And then I've used other saliva tests, other urine tests, but this one in terms of the clinical data, the way that they break things down, I find it really helpful. I know there's other tests that do urine, so if that works for you, that's great too. So when you look at this graph here, it's pretty confusing to start with. I show this to a patient, I say, don't worry about this. It's just for us to help give some information about when we're looking at all what's happening with the hormones. But I do like to use this as a representation for us to see just how complex the sex hormones are. We know that all the sex hormones will start off with cholesterol. Cholesterol is the backbone for all of them. This is important to think about in terms of digestion and are people absorbing and metabolizing their fats properly. From cholesterol, we get pregnenolone, the first and precursor hormone to all of the sex hormones. But in this pathway too, we also have cortisol. And this is something that a lot of people don't necessarily think about, is that cortisol is in the same pathway as all of our sex hormones. So this is really important when we're thinking about stress, inflammation, and pain. It's how it's interrelated with the sex hormones. There's been some interesting research on females and having increased urine cortisol when they're having difficulty with sexual arousal and having stress related to decreasing sexual performance. It interferes with some of the other hormones that are necessary in order to feel the want to copulate. So it is something to think about when people are having difficulty with sexual arousal. So pregnenolone, as I mentioned, the mother hormone. It's the hormone that all the other hormones in terms of the sex cascades are produced from. This is a little snippet from the Dutch test. So we have pregnenolone in one pathway here broken down into progesterone and its metabolites, and then the other pathway into DHEA, the androgenic hormones, and then into estrogens. I wanted to show this graph just so you can see a basic overview of how the hormones are broken down and how progesterone is in its own pathway and the other sex hormones are taken from pregnenolone down into DHEA and further broken down into other metabolites. So sex or hormone summary, we typically would be looking at estradiol or E2, progesterone, and testosterone. These ones are more produced by the gonads, the ovaries, and the testes, versus when we look at cortisol and DHEA, these are primarily produced by the adrenal glands. These are important to consider when you're looking at how the hormones can be dysregulated and which ones tend to be out of balance. Estrogen is typically summarized by E2 in a lot of literature, but it is important to look at the individual types of hormones on top of this. And DHEA is often looked at in its active form, DHEAS. We'll discuss that a little bit more. So the stress pathway here, pain causes a lot of activation of the stress pathway in our body. We have the release of ACTH, or adrenocorticotropic hormone, from the pituitary gland. Downstream, this stimulates the adrenal glands, which will raise serum cortisol levels as well as other adrenal hormones. This causes a change in the renin-angiotensin-aldosterone system and impacts our heart rate, blood pressure, and this is common when we see pain flares. We will see an increase in the heart rate and blood pressure of patients when they're having more pain. And when we see high serum cortisol levels over time, this typically it means that people have uncontrolled pain or pain that is not being dealt with very well. We almost always see high or borderline high in acute stressors and acute pain, and then chronic pain, sometimes it will start to decline because it is wearing the system out and we're producing too much of it. Most human diseases are related to this type of system, and chronic inflammation is something that is an essential component of many chronic diseases. So the inflammation cascade utilizes a lot of resources. And I wanted to show this so that we can think about those cardinal signs of inflammation: redness, heat, pain, and swelling. So all of these resources that are making these symptoms of inflammation are advantageous in acute scenarios where we're trying to do something quite quickly and the body is trying to receive information about what's happening. When we look at evolutionary medicine, these inflammation cascades are not advantageous when we're looking at chronic pain and chronic inflammation because it requires so much energy to produce these things. Inflammation really impacts the thyroid on top of that. We have all these inflammatory markers being created. As a result, we often have oxidative stress and the markers that are increased during oxidative stress. And then this will typically lower thyroid function. So if you have patients that are hypothyroid or low thyroid functioning, then we want to make sure they're not in states of oxidative stress or chronic inflammation to help prevent that thyroid from dysfunctioning and make sure that we're correcting that and making it work better. At these resources, you can see that the low thyroid function actually will induce increased state of oxidative stress. So this is cyclic. We have low thyroid, more oxidative stress, which makes the thyroid worse and is something that we do need to correct. This is a pretty direct slide here about how cortisol, pregnenolone, and cholesterol are interrelated. When we have severe uncontrolled pain, we exhaust the adrenal glands and we will lower the amount of pregnenolone that is produced in the body as a result of this. Pregnenolone is really important because it is the mother hormone, the precursor hormone to most of our sex hormones, and we need it for a lot of different scenarios. When we look at pregnenolone, it's plentiful in the brain. It performs multiple functions, including regulating GABA and NMDA receptors. And then when we see testosterone, estrogen, and progesterone, it actually helps it to cross the blood-brain barrier. So we need pregnenolone for the other hormones to work properly and to also help create them. So an important relationship there. A lot of pain relief mechanisms will require a low amount of testosterone to be present and some of these other hormones. So if you find a patient that does not have opioids working very well for them, they're taking things like tramadol, it's not really working, it's probably because some of these other hormones are not present to actually help them be receptive at the receptor sites and to encourage them to work properly. The pituitary adrenal response that occurs from a pain stressor, there really isn't anything bigger than pain in terms of the stress on the body and how we react to it physiologically. Along with things like fright, shock, trauma, surgery, it activates the hypothalamic pituitary adrenal as well as the gonadal systems. And the hormone's first response is, including pain, is to release the adrenaline, cortisol, pregnenolone, and other hormones. At the time of activation, these can be measured as being high in serum, and we can also see this in saliva and urine. But as you can see, when this happens over the long term, this is not advantageous. An interesting study looking at hormonal fluctuations, daily fluctuations of progesterone and testosterone. This was in a group of women that have fibromyalgia. We looked over a month or so in the study. Sorry, I wasn't a participant in the study or doing it, but the researchers looked at it. And we found that fibromyalgia flares tended to occur when progesterone and testosterone were their lowest throughout the month. So there's a pretty big association with most of these patients having chronic flares when some of these levels were lower. And it makes sense because a lot of these hormone molecules help to reduce pain and make it a little bit better in the body. So progesterone. Progesterone is a metabolite created in its own pathway from pregnenolone. I showed you in that slide there a little bit ago. In females, it provides the role of getting the endometrium ready as a potential for pregnancy. And it helps to do a lot of things like decreases inflammation, helps with sleep. This was both with females and males. In males, it influences spermiogenesis, and testosterone production is really needed with progesterone too. It actually helps with the production of testosterone in a Leydig cell, even though it's on its own pathway. It is important for both females and males in terms of having proper amounts of hormone production. It's really regenerative, and because it helps with sleep, you're usually helping with energy and mood. So it really helps in a lot of different facets of life. It's critical in metabolism, immune function, and we have found an association with it in chronic pain. Things that lower progesterone or anything upscale, so anything that will decrease pregnenolone production, anything that is causing a stressor in the system. Low cortisol levels, because it is the precursor, it's important that people are breaking down their fats properly. Ovarian failure and menopause, as well as miscarriage, are some other scenarios where we would see progesterone low, and pituitary dysfunctions. We're not stimulating some of the things from the brain to help us release progesterone. And pain itself. Things where we'd see high progesterone, this is not nearly as common as low progesterone, but normal things we would see it with are including pregnancy and ovulation. Some unwanted causes, typically when we see high progesterone and someone is not pregnant or right around ovulation, we typically will test slightly after ovulation to help rule this out, is ovarian cysts, ovarian cancer, adrenal disorders, and molar pregnancies. So pregnancies that are characterized by abnormal development of the placenta. It's not a true pregnancy. Unfortunately, it doesn't result in a child or anything further downstream. So something to keep in mind when you're thinking of why people would have high progesterone. DHEA, this is one people don't tend to know quite as much information about. It's certainly in my practice something that my patients don't seem to know enough about. DHEA and cortisol, because they're both produced in the adrenal glands, tend to be one of the hormones that is impacted the most when we're having chronic states of inflammation and in chronic pain. I lovingly refer to it as a graceful aging hormone. So something that helps us to have better skin tone, better longevity, and helps us to have more signs of improved health as we get older. We're typically looking at DHEAS as a form of DHEA. This is the sulfated form, the form that is more active in the body, but there are a couple of other metabolites that are created from DHEA when we're looking at the total levels. You do want to consider more the DHEAS when you're thinking about if you need to supplement this. Because DHEA is not something that we can prescribe, neither is testosterone. Often I will help by increasing pregnenolone levels. This is something we can prescribe, but you need to be very conscientious about what's happening with the other hormones downstream. And we'll discuss this because we don't want to imbalance things like testosterone, estrogens, if downstream they're high. If you increase DHEA, it will also break down into those hormones and metabolites. Things that lower DHEA levels include adrenal insufficiency, Addison's disease. So Addison's is an uncommon disorder of the adrenal glands where we don't produce sufficient hormones. Typically cortisol, aldosterone, and DHEA are impacted by this. It's most often caused or linked with, I should say, tuberculosis. So if you do have a patient that has a history of TB, then this is something to consider why DHEA would be imbalanced. Low functioning pituitary gland and hypothyroidism. We discussed how thyroid will cause a lot of oxidative stress, or maybe that oxidative stress caused the low thyroid function to begin with. That's something that's associated with lower DHEA levels. And then glucocorticoid prescriptions. We'll see higher amounts of testosterone when we see glucocorticoids, but lower amounts of DHEA. So something to think about when you're doing testing is if a patient is on these things, as well as it could be causing imbalances. So anything we can do to get them off of them is really important. High DHEA is much less common, but tumors, genetic disorders, and PCOS or polycystic ovarian syndrome are the most common reasons why you'd see high DHEA. I did want to make a comment about DHEA being available over the counter in the States. So a lot of patients will order it online and get it shipped directly to their homes. This is something to be cautious of. Same thing with supplements. When you're ordering from a supplier, you don't necessarily know how they're creating things, then we often will see low quality DHEA being contaminated and have other things mixed in with it. And these are things that could influence hormone levels in a way we don't want them to. So be cautious of this. I know we can't prescribe it, but I do know some patients that will order it online. So this is something that I typically do not encourage people to do. If they do need it and we don't want to prescribe pregnenolone, then we will try and get this from an MD so that it can be done properly. Testosterone and pain. So testosterone, we think of this typically as being a bodybuilding hormone, something to improve muscle mass, to help slim the body out, but it's very important for a lot of different reasons. It's mainly produced in the gonads, ovaries, and the testes. In males, it promotes function of the maturation of the spermatozoa. Accessory organs are something that it also helps to produce, but quite important for the stimulation of bone and muscle growth. And this is both in males and females. So if you have someone that has osteoporosis, osteopenia, where the density of the bones is not sufficient, testosterone is often directly linked with this, as well as progesterone. So we need all of the sex hormones to be in balance for bones to be strong and healthy. Something to look at if your patient has any sort of symptoms of that, you want to look at hormone testing. So things that cause low testosterone would be DHEA. It's directly upstream, same with pregnenolone. Diseases of the kidneys, liver, or lungs. Often we find that higher toxic states will decrease the rate that testosterone is able to be produced, as well as directly interfere with the production. And when the liver is not working properly, then it cannot transform and make hormones from one form to another as easily as it should be able to. Low pituitary functioning, this is with all the hormones. And then type 2 diabetes is more associated with testosterone. And then there's a lot of food things that are associated with lower testosterone levels too. Dairy, alcohol are common ones. And then anything that will cause inflammation in the system. So this might be one case for food sensitivity testing if necessary. In high testosterone, anabolic steroids is the most common reason we will see this, as well as some tumors. Polycystic ovarian syndrome, same with DHEA, will also increase testosterone levels. But contaminants are another thing to really be careful of. When we look at a lot of protein powders, especially that are geared towards muscle building, we will often see contaminants in there and when you look at some of the research on these products who have a third party looking at what's in there, it seems like some companies will actually add testosterone in very low amounts to help improve the effectiveness of the product. So I always discourage low quality protein powders and things like that from patients getting them. I always want them to get better quality ones. And this could do other supplements, things that are supposed to increase testosterone herbally when they're from non-reputable sources, trying to avoid these as much as possible. Estrogens, certainly one of the most complex when it comes to the sex hormones. We have 4 major types of estrogens, 3 types that are typically in the body most time frames, E1, E2, and E3, although E3 is typically present mostly in pregnancy. That's estriol. And then we have estradiol, which is E4. This one is only present in pregnancy, and it is just produced by fetal liver tissue, so we'll only see it in that time frame. All 4 of these types of estrogens are important to think of. The first 3, E1, 2, and 3, when we're looking at balance in the system for a non-pregnant woman or with males. And all of these metabolites will break down, all the types of estrogens will break down into mostly 3 different metabolites. I found that training for estrogen metabolites was not as sufficient as I would like it to be. And the reason why the metabolites are really important to consider is they will typically impact the long-term negative effects of estrogen more than the whole hormones do. 2-OH21 is considered more of a beneficial positive metabolite. It's something that we want in larger amounts. 4-OH21 is considered a more toxic metabolite. That's one we usually see damaging DNA most often. And then we have 16-OH21, which is considered a more neutral type of metabolite, but it is the most estrogenic of the 3. So if someone has higher amounts of 16-OH21, but lower amounts of estrogens, they could still have amounts of estrogens that are functioning well in the system. So we need to look at the metabolites and their estrogens in terms of how estrogen is working in the body and what's happening. E2 is the one we usually see most commonly with testing, but I have seen a lot of scenarios where some of them are high and some of them are low. So it's better to know what's happening with all of them so that we can treat as effectively as possible. When we look at estrogen ratios, we also need to consider progesterone values. We always want more progesterone than estrogen. We need it to balance the estrogen and possible negative side effects that it might have in the system. So we'll often see that the ratios of these things are off. When we look at the breakdown, we have those 3 major types and then the types of metabolites as well as their ratios. So this is a nice little graphic representation of typically what we want those metabolites to look at. We want a lot more of the 2-OH21. We want about 75% would be ideal. We want less than 10% of the 4-OH21, and the rest is typically 16-OH. Now, this is made downstream from DHA and testosterone, primarily in the gonads. And we want to keep in mind that 4-OH21 will cause oxidative damage. And typically when we see those ratios imbalance, we do want to use estrogen binders and things that will help to correct the ratios. However, when we are doing this, we will often cause a decrease in the total amount of estrogens. So if you have a patient that has ratios that are imbalanced, but their total amount of estrogen is lower, then you do want to try and supplement with something that either herbally will increase estrogens or something that will, like a prescription, will improve the estrogens. When we talk about estrogen prescriptions, we're usually trying to use the metabolites or the way that it's going to cause metabolites to be less toxic. So that would be topical whenever possible. There certainly are some scenarios where I would use oral, but whenever we have a preference for the ability, typically we want to use topical. And this helps to produce less of that 4-OH21 metabolite. That's why we often will prefer that type of prescription. And when I prescribe estrogen, even if a female doesn't have a uterus and a cervix, I will still look at how those estrogens could potentially cause damage to other areas in the body. So there's never been a scenario where I would prescribe estrogen without progesterone, just because I want to make sure that they're balancing each other. There might be some scenarios where patients have come into my office and they haven't been on one, and I will typically encourage them to be, but to be as safe as possible, trying to be preventative, which of course is one of the premises of the naturopathic doctors. one of our principles, then we want to have the least potential for harm as possible. So you're welcome to ask me some questions about this, but progesterone and estrogen are almost always something that I would prescribe together. When we think about estrogens and pain, we think about things that lower progesterone. As we indicated for the other hormones, chronic stress is something that will typically steal from these pathways. So we find lower amounts of estrogens as a result. Low DHEA and things that lower it. Being underweight and exercising excessively will often decrease estrogens. And things like congenital syndromes, Turner syndrome is one of them. This is where there's a mutation or a lack of one of the X chromosomes, so that only happens in females. In Turner's, we don't develop ovaries and sexual characteristics, so we're going to have a lack of hormone production in that case. Something to rule out if you see someone that lacks a lot of the secondary sex characteristics. Things that increase estrogens. So high estrogens is something that I will see quite commonly. And this is something that we want to take care in treating. Xenoestrogens and phytoestrogens are things that will increase estrogens in the body. Xenoestrogens are chemical synthetic forms versus phytoestrogens are foods that will increase estrogens. They're plant derived. Things like plastic water bottles, Tupperware, but things that might not be as obvious like makeup, nail polish, other things you're putting in your body, and then chemicals, pesticides, and water systems. Water is something that we are finding higher amounts of estrogen in, so it's getting more and more important to filter your water to make sure we're getting things like this out. But if people are using a basic system like a Brita filter, then we're typically not going to be filtering things like estrogens. I'll talk about water quality and some things to do about that a little bit more. And then medications are another one we'll see that increase estrogens. They're obvious ones like ones that have estrogens in it, typically oral contraceptives, but steroid medications will increase them. Ampicillin is another one, and tetracycline is another medication. So if you have a patient with a history of acne that they've used tetracycline for, then it's something that you want to rule out as increasing estrogens in the body. Then alcohol overconsumption is another one we would see often causing high estrogens, but interestingly enough, typically causes low testosterone. When it comes to progesterone and estrogen balance, we need more progesterone. How much more is highly debated. There's a lot of different information and literature about the exact ratios that we want for progesterone and estrogen. Usually we're looking at the estradiol E2 specifically for this in relation to progesterone. But for menstruating females, usually we want about 100 to 500 times progesterone to estrogen. We are usually looking at this in the luteal phase. This is important to consider because it will vary quite widely throughout a menstrual cycle. Postmenopausal ratios, not quite as clear, even being unclear to begin with, and they're about 100 to 300. For males, we usually want about 200 to 300 times progesterone to estrogen. But it is clear we need quite a bit more progesterone, and this is to help balance out any potential negative effects that estrogen has. This is typically why I won't see many scenarios where I would prescribe estrogen without progesterone, but we very rarely see progesterone high and estrogen low. There's an interesting rat study that looked at increased progesterone in relation to estrogen, and we did find that the decreased estrogen and improving that progesterone ratio will help prevent oxidative stress in both the uterus as well as when we looked at some plasma markers. Unfortunately, I think this was hard to do on humans because they were doing things like actually looking at the uterus tissue. So you'd have to do a biopsy of the uterus in order to look at those levels. But when we're looking at serum or urine levels, then we definitely think that this is important. When we look at bacterial balance in estrogens, beneficial bacteria seem to be a really important part of maintaining that ratio of good estrogens. When we see a big imbalance in what the estrogens look like, then we do want to take a look at digestion. Always important to have a good digestive tract, but maybe that patient isn't experiencing many symptoms of digestion being off balance. This is one scenario where we would still want to look at them. I would often do some stool testing to check this because it'll give a good idea of the good versus bad bacteria present. if there's any parasites or other infections that need to be treated. Yeast will often be picked up in there, and then we'll look at breakdown products of fat and carbohydrates to make sure the body's doing these things properly. One link I often send my patients to, which is quite helpful to look at any sort of xenoestrogens or other chemicals playing a negative role with hormones, is EWG.org. EWG is a company that has taken resources from many different products, mostly household products, cleaning products, things that you put on your skin, other things in your immediate environment, and we'll give them a rating as to if they are harmful or something that is unharmful. This is helpful for patients to go through their cupboards, their makeup, different products, and see if some of them are actually considered more toxic. The interesting thing about EWG.org is they will break down each individual ingredient in the products, which I find really helpful for people to know. They will explain if they're impacting the thyroid, if they're creating oxidative stress, if they're imbalancing other hormones. So it is something I find quite helpful. One thing to consider with this website, however, is they do consider essential oils as a negative thing on here. So that really depends on the quality of the essential oils. If an essential oil is sourced from a good product, then it's probably something that is not going to create any detrimental effects. So they do give things a slightly more negative rating that have essential oils in it. So I just tell my patient to make sure they know how those things are sourced, and then if they would be something that would be harmful or not. The other thing estrogens play a balance in is the metabolite ratios, but xenoestrogens do seem to be impacting good bacterial balance. So they actually will deplete and decrease some of the good bacteria in the body. So that's one reason why we really want to keep an eye on them. Some other things I've seen, interestingly enough, with practice is a correlation between SIBO and hormonal balance. I've had a few patients come into my practice. We've done lots of different digestive treatments. We've done quite a few things with digestion, and until we balanced hormones, digestion wasn't better. So another link between digestion and why hormones would be good to take a look at. So this slide's a little bit complex. I apologize for that, but liver is so important for so many different reasons that I wanted to include a few different things on here. When we look at liver markers, so blood work that would be associated with liver functioning, often we will see normal liver results. But when we look at the hormone results and other things that are going on with that person, we would often see some reasons why we would suspect the liver is not functioning optimally. So suboptimal reasons the liver would be functioning still need to be treated. Liver support is very important when we see the ratios of hormones being off, people being in more pain. Toxic metabolites can build up quite quickly when the liver is not working properly. And there's things like mutations in the genome with SNPs, single nucleotide polymorphism, that will impact liver function. We'll talk about that a little bit more. So the liver is also needed to transform hormones from one form to another, help with the ratios, as well as detoxify them. Without that proper functioning, we'll see all kinds of imbalances. Well, as I mentioned, the hormonal portion, but also we will see increases in inflammation, and that inflammation will cause an increase in stress. So a lot of cyclical events that happen here between hormones, toxicities, stress, pain, and inflammation. Alpha was something I wanted to highlight as well. The reason for this is I've mentioned cholesterol is the backbone for all of our sex hormones. When we don't have enough of that backbone, then we are not going to be able to create hormones to a sufficient degree. When someone has a gallbladder that is not functioning properly or are missing their gallbladder, then we're going to have a disproportionate amount of cholesterol being put into the system so that we can create hormones. If someone doesn't have a gallbladder or their gallbladder isn't functioning properly, I typically will supplement it with ox bile or other enzymes that help with fat breakdown. And the other thing to consider with fat breakdown too, is the fat soluble vitamins getting put into the body properly. Particularly one that I'm concerned about is vitamin D. Vitamin D is linked with autoimmune conditions, inflammation, and pain in the system. So if your bowel is not working, you're not secreting it when it should be, and you're not getting enough cholesterol into the system, then we will often find vitamin D is lowered, and there's a pretty big association between autoimmune conditions and vitamin D deficiency. Some genetic mutations that could impact pain are typically have to do with a few different systems in the body. When we think about genes themselves, it takes 1 million years for genes to actually change. But genes can be expressed differently. The way that they are turned on and off can change. So single nucleotide polymorphisms are something that contributes to individual variations in how we respond to things. When I see patients, I often will have people from multiple generations come see me, and this adds a lot of really good clinical insight into the family traits of what might be going on with these patients. I often do see different traits like depression, anxiety, emotional conditions being seen over multiple generations. And one of the reasons why some of these things could occur are the SNPs of those patients. We will see some of these genetic things being carried on over time. And methylation difficulties certainly seems to be one of them. I find methylation ones are most common when I have patients that are more anxious or have depression, bipolar, schizophrenia, things along those lines. It's also very common in pain syndromes too. The A1298C mutation of MTHFR is associated with fibromyalgia, IBS, fatigue, chronic pain, so some pretty big disruptions in how it would be impacting the body. MTHFR will impact liver function because the liver needs methylation, the addition of a methyl group to detoxify the body, but also to transform hormones from one type to another. So we'll see quite a bit of variance between these things. I am celiac, so this next one is definitely something that I think about. HLA-DQA1 is a variant common in celiac disease. So if a person is having difficulty breaking down different forms of gluten, and in celiac specifically, it will actually attack the intestines, the small intestine, the villi specifically, will have a lot more pain and inflammation. Even when people are having a dedicated gluten-free diet, we do see some other factors that will impact people that have this variant. And some of these people are often sensitive to a protein in oats as well. So oats and gluten are two things that can affect people with this variant. Another thing that people might not necessarily have known much about is there's some mutations that can occur in voltage-gated ion channels, and specifically with calcium movement across the membranes. When we don't have calcium moving across the membranes, we often will see more electrolyte imbalances, and this can be associated most often with neuropathies. With things like MS, we've seen quite a bit of increase in voltage-gated ion channels not working properly. So that's an interesting one. With male versus female differences, there's a few things that are important to consider. With males, we'll see higher amounts of the androgenic hormones, so testosterone and DHA. With females, we'll see higher amounts of estrogen and progesterone. But the amounts that we usually see, the ratios will differ, but we always need more progesterone than estrogen in both sexes. And drops of DHA and testosterone don't occur as fast in females as drops in estrogen and progesterone do when we hit menopause. So that is important to consider when we're looking at the balance of the hormones. In females, that occurs quite quickly, and in males, that occurs more over time. So that would be andropause, where we have a slow decline in hormones over time, versus menopause, which often happens quickly. Unfortunately, for some women, it does occur over several years, but how those hormones are changing is different in males and females. Xenoestrogens are one of the things that would be throwing things off balance here. And one thing I wanted to talk about was soy. Soy is one of the phytoestrogens that is often talked about. What I have found with most of the research is soy really depends on the quality. So soy itself is more estrogen balancing versus estrogenic. So we want to make sure that we're having good quality soy if we are consuming it. And I have seen it recommended in cases with cancer, even with estrogen dominant cancers, because it can help to regulate the estrogen levels versus increasing them. So this is something you want to use with caution, but if someone is eating soy, just make sure they're eating good quality, and it will help to be a lot more balancing. When we're talking about the xenoestrogens and water quality, that's something we want to make sure water is really balanced. So different parts of the world will have water that has some pretty major contaminants in it, but I've also seen this on some of the islands. I've done quite a bit of chelation therapy, so I look at different toxic elements that could potentially be in a system. And on some of the islands, I worked on Salt Spring for a period of time. We've seen some things that are not considered toxic when we look at Health Canada levels in water, but we look at the balance of them. They will be throwing off things like the thyroid, they will be impacting liver function. So just because things are deemed safe in water, it doesn't mean they're not impacting things like pain and hormones. So something really important to look at. Some common nutritional deficiencies would be things that are impacting methylation and the thyroid gland, but impact pain and inflammation as well. B vitamins, especially B9 and B12, but 5 and 6 are also important for stress. And because all the B vitamins work together, I don't typically like to prescribe an individual B vitamin. I will encourage the use of B9 and B12 if B12 is clinically low, but I usually like people to get a B complex when possible. Magnesium is another thing that is important for a lot of reasons, has so many functions in the body that we can't even name them here if I was sitting here for an hour. So in terms of methylation detoxification, it's something we think about, but with hormonal and pain scenarios, it's something that can be quite helpful. Glutathione to help with detoxification, energy production, and the balance of the system, and other vitamins and minerals that support the methylation process. Iron is something that is quite interesting when we think about pain. It's something I usually will test when I'm looking at pain syndromes because we want sufficient amounts of iron for people to be able to heal from an injury properly, but we don't want too much that it will start to become oxidative. So if you have a patient that comes into your office, I usually do ferritin in combination with total iron to make sure that there aren't some reasons like infection and inflammation that would be increasing the ferritin levels. And then I'll combine it with CRP, C-reactive protein, as well as a CBC or complete blood count. And the reason is I want to make sure there's no obvious infection or inflammation in the system. When it comes to ferritin, that marker for iron, we usually want to see it around 60 to 90. 90 is better, especially if you're looking at a menstruating female or females thinking about becoming pregnant. We don't want to see it around 5, 15, anything on those lines, because we will see that impacting your ability to heal. I've seen this in some runners, people that are exercising at higher rates, their iron levels will be depleted. And this does happen with vegans more often than non-vegan adults. And we do see this in kids. If kids are fussy, this is one of the nutrients we see quite low. So the balance of iron is really important to look at. Vitamin D, important for autoimmune diseases, hormone problems, a lot of reasons. And buildup of pro-inflammatory markers can also be something that we need to be cautious of. Lifestyle contributors, so many lifestyle contributors that are influencing pain. But if a person is in a toxic state, that's something that will really be important to consider. Sorry, my light just turned off because I'm not moving around enough. Shift workers and people that have irregular schedules. So this would be people that have night shifts, especially. It is something that will create more stress on the system and is often associated with more chronic health conditions. So if your patient was able to change something like this, make a lifestyle change or a job change when they're working night shift, then it is something that I really encourage. The number of hours sitting per day is something that's associated with most chronic health conditions. So it's important to get up, move around, encourage people to be exercising, even if it just means walking down the block. Patients that come in that are obese, morbidly obese, then having difficulty moving around, still trying to encourage them to get up and down every half an hour or so, making sure they're not sitting for long periods of time. Sleep quality and quantity. So not just the number of hours you're sleeping, but how well you're sleeping, as well as when you're sleeping. Exogenous estrogens, we want to decrease those as much as possible, and then think about dietary factors, allergies, sensitivities, and digestion, and the amount of stress. So is this something that's occurring really frequently? Is it something that we can do to decrease in the patient's life? And those water contaminants. Blood sugar balance. When blood sugar is out of balance, it will create more inflammation in the system and is more common in autoimmune diseases as well. Higher blood sugar is correlated with an increased amount of disease. When we think back to my patient that had type 1 diabetes, the one symptom she had of pain was leg cramps. Now, if I didn't ask about being thirsty, it is something that we might have just thought of, well, let's give her a good quality electrolyte, make sure she's hydrated properly. She wasn't having what she would describe as frequent urination, which would be another symptom as diabetes. So something that you want to consider when you're thinking about pain is blood sugar balance. Let's talk about a case now. I had a patient that I've been seeing for a couple of years come into my office. She was having chronic gas and bloating, abdominal pain. She had some food sensitivities that she was aware of. She has chronic iron deficiency anemia. She had normal thyroid function, and most of her other blood work was within normal limits. We did a stool analysis. She'd already been tested for SIBO in the past and had treated it. The stool analysis did show some mildly dysbiotic flora, and then we did do a SIBO test too to see what else might be going on, and she did have some hydrogen positive flora. Another thing she had were frequent urinary tract infections. They usually occurred every few months. She was put on cranmanos, one of cytomatrix products I like a lot for urinary tract infections. We balanced her intestinal tract out, did a SIBO protocol for a couple of months and continued on that diet afterwards. And she was still experiencing some mild bloating and pain around the menstruation. As far as we could tell, most of the digestive markers looked better, but she was finding introducing new foods especially was quite difficult. When we put her in the cranmanos, her urinary tract infections improved, but because of that persistent bloating and some pain, we did decide to test her hormones, especially since the hormones seem to be associated with when she was having that bloating and discomfort. It was usually happening before her menstrual cycle. We found that the patient generally had lower hormones. She was put on oral progesterone at nighttime. Oral progesterone is better for sleep, and we do find that many types of progesterone are helpful for pain, but if someone has low energy, difficulty sleeping, then I will usually give them oral progesterone. Sometimes I will combine it with topical too, but oral I find at nighttime in an immediate release form is best for sleep. We put her on topical biased, which is a combination estrogen in the morning, and then did some liver support, vitamin support, methylation support, and then her ratio of estrogens weren't ideal, so we did put her on estro matrix. Even though her estrogens were low, we added the biased from the chemical perspective to improve them, and then estro matrix to help balance out the ratios so that it was as protective and working as well as possible. She had improvement in bloating within 3 weeks of starting this protocol, and after a couple of months, she was able to start reintroducing food without any difficulties. Her energy and sleep improved, so it did make a big difference to help balance out her hormones even after all of the digestive stuff that we did. We continued her on probiotics, which had been part of her SIBO protocol, her hormone replacement therapy, estro matrix, and cranmanos. After about 4 months on this routine, she, interestingly enough, ran out of her estro matrix. I didn't have any in stock. It took me a little while to get it back in. And when she was off it for about a week, she started getting some of her digestive symptoms returning. And this happened quite quickly. We took away the estrogen until she got the ester matrix back in, and she felt better after stopping it. So it was an imbalance in the estrogens that was likely causing some of those symptoms. When she started back up on the ester matrix, I told her to pause the estrogen for a week or so longer just to help balance things before she put back in the biased. And then once she put everything back in, she felt a lot better. So probably the most part of the talk, let's talk about some therapies. So we've mentioned some dietary factors being really important in the management of pain. Gluten, dairy, and sugar are probably the three most common things I find increasing inflammation and increasing pain in patients. Some of the things that are hardest to cut out, but definitely some of those basics, the nutritional factors are really important and can help people out quite a bit. Trying to avoid common aggravators, balancing those blood sugars, and this is certainly a scenario I would do food sensitivity testing. I always like patients to know food sensitivity testing is not 100% accurate. No lab test is, so with our clinical judgment, we interpret them and help the patients to be avoiding things that we think are most likely to be causing inflammation. Mindfulness and relaxation. We're all doing too much. Having a moment to breathe, to make sure that we are not breathing in a shallow manner, is something that will have a direct correlation with improving stress. I did a research paper on how anxiety and stress are interrelated, and we do see a very strong correlation there. And having people that breathe shallowly, do not have diaphragmatic breathing, will increase your stress in the system. So something as simple as breathing on a regular basis, making sure you're getting that oxygen in efficiently, will help that person to feel less stress, have less inflammation, and be in less pain. So slow people down as much as you can. Another way that I have people implement a little bit more of a nutritional balance. These are pictures from my own garden from the last couple of years. I have a pretty small backyard, so you're able to do quite a bit in a small space. But encouraging that connection with food. This is something that's really important for children, for adults, anyone. And having a whole foods diet, this is very helpful to having a little bit of a garden. Even if you have a small patio or you're in an apartment that doesn't have a deck, you can still grow some herbs, some small plants. It's something that helps people to have a better understanding about how that nutrition will impact their body. Having an anti-inflammatory approach to diet is something that I try and focus on. I do have a pretty good handout for this. If anyone wants it, please feel free to contact me or Cytomatrix after the talk. And water. So not only having good quality water, making sure it comes from a source that is as fresh and as non-toxic as possible. You can get water testing quite easily nowadays. So it's something that I encourage whenever I think it might be an influencing factor, especially if people are on wells. But even in Victoria, we see some water that is not as good as we'd expect it to. If people are drinking lots of water and they're not feeling hydrated, then we need to look at the electrolyte component. Are they having enough electrolytes to actually absorb that water properly? So increasing the water and then increasing a little bit of electrolytes in the body can also help that. A Berkey filter is something that I use or recommend a lot of patients use to help filter water out. It has some pretty interesting studies associated with its capacity to filter out toxicities. And it's been used in many different scenarios, even from mud water, and it's able to filter out things pretty effectively. So that's one system I do like. And then organic versus local. I wanted to have a quick note about this because organic food can be quite good, but the certification does not look at soil quality, toxicities in soil. It just looks at what is sprayed on the food. And it does look at chemicals from the soil, but not things like arsenic or aluminum or other chemicals that might be in the soil that would be absorbed by foods and taken in. So it's not the be all and end all. I usually prefer local over foods that are grown foreignly. And this is because local soil here is a lot better than some other areas of the world. And because foods don't have to be irradiated to come over the border when they're local. Local people also have more of an interest in our health. So if something is local and unsprayed, I usually will prefer that to foreign organic foods. Sugar-free, so something that's hard to convince people to do, but lowering sugar is key for inflammation and decreasing chronic pain as well as autoimmune conditions. Natural sugars, I always try and emphasize over processed sugars, but some natural sugars are better than others. Many foods will spike blood sugar. This link that I have here is a list from a company called Levels Health. They had people that were monitoring their blood sugar with continuous blood sugar monitors, so quite easy to see how foods are impacting blood sugar. They had a large subset of people that they took information from about which foods were likely to spike blood sugar, and they made this form of 110 different foods that are unlikely to spike your blood sugar, ranging from vegetables, nuts and seeds, fruit, and other things. So that's one area I will often point to patients to. Monk fruit and stevia, I find, and also in the Levels Health form here are good in terms of not spiking blood sugar. And then if people want some other sources, I do allow a little bit of honey and maple syrup, but try and focus on lowering sugar as much as possible. Sleep quality and quantity. I mentioned this, but I did want to discuss the timing for sleep. I have a lot of patients that are parents, are busy workers. The only time of the day they really get to relax is later in the evening. And I really can't blame this for them, but they often will stay up later until midnight, 1 a.m., sometimes later. And we do know that when you go to bed past a certain time, which seems to be around 11 p.m., it takes more time for the body to regenerate with the same amount of sleep. So you do need to get to bed in order to reset their circadian rhythm, to help with healing and reset the body. So I usually say bed no later than 11. So hormones. I mentioned at the beginning of the talk that I found progesterone was really helpful for my pain, to help me sleep and to help balance out the body a lot more. Pregnenolone, because it is that mother hormone, when hormones are generally low, is something that is really helpful to improve the production of all the hormones. You just want to keep in mind the ratios as well as estrogen and its metabolites, improving nutritional factors so that we can actually produce as much hormones as we need, and then regulating cortisol and inflammation, so these aren't stealing from the hormone pathways. Balancing all the hormones is really important, and then regulating other organs that might be impacting them. Acupuncture for pain is something that can be quite helpful, but you do need to do it somewhat frequently. For acute pain, it needs to be done probably at least 2 or 3 times a week for a period of time. And for more severe pain or chronic pain, it does need to be done quite frequently too. Keep this in mind for effectiveness of acupuncture. If you're only doing it once a month or every few weeks, it's probably not something that is going to help other than with just stress in general. But with more severe pain, you do need to be have it more often. And you can add in ear points and moxibustion to improve the effectiveness of acupuncture. I do have some protocols here. I won't go over this. This is more just for your reference, and you can look at this afterwards. Infrared laser is something I use in my practice. There's a couple different classes of lasers. I've used both 3 and 4. I have found 4 to be more effective. Now, this is my opinion. You might have had different experiences, but I do find because it is warm, it's active, and I can decrease its intensity in the area. I can have more firmness or less firmness. That it is something that I find quite effectiveness for local pain. It helps to reset nerves, decrease inflammation, and balance the area, but it is more inflammatory modulating versus anti-inflammatory, and that's important to think about. We don't want things that are cutting off inflammation altogether. We want things that are moderating the inflammation. We need a little bit of inflammation for healing to occur. So inflammation in itself isn't bad. It's not advantageous when we either have it for longer periods of time or if it's too much at once for the body to handle. Low-dose naltrexone. This may be something you know about in your practice, or it might be something that you're not familiar with, but it is a tool that I've used quite a bit. Low-dose naltrexone is an opioid antagonist, so it binds opioid receptor sites. You'll probably recognize naloxone, which is a derivative of naltrexone. So it's used in opioid cases where people have overdosed. When we use naltrexone at low doses, we find that it helps to modulate the immune system and modulate inflammation. So it's regulating those levels. We're typically taking it before bed at doses between 3.5 and 4.5 milligrams. Now, there is a protocol for this, so you don't just want to start people on it. You do want to think about it. Feel free to ask us about that if it's something you're interested in. But there's quite a bit of research on autoimmune diseases, inflammatory bowel conditions, immune dysregulation, and general inflammation. Really, it's helpful for any chronic disease that would be related to inflammation, immune system, or stress. Injection therapies, there's lots of different injection therapies. I do quite a few of these. I have found a combination of this, as well as with dietary factors, lifestyle factors, to be quite effective, but really depends on the individual person, what they want to do, their funds, things along those lines. IV therapies. This is really helpful for people that have digestive disorders and inabilities to absorb nutrients at the proper rate, as well as people that are having more chronic stressors because the system gets so depleted. The purpose behind IVs is we're trying to decrease oxidative damage and inflammation. We're trying to improve nutrient absorption and assimilation, blood sugar regulation, and cellular function. We might think about things like ozone, stem cell therapy, and some other therapies intravenously, but typically I'm doing electrolytes, vitamins, minerals, B vitamins, amino acids. Those I use most frequently, and then there's other things like NAD or other therapies you can do. Homeopathics are something that I have found to be quite helpful, especially for more complex cases or people that are more sensitive. Single remedies, if it's something that I'm not quite sure what the case would be. I don't typically do a full homeopathic intake, so I will send those to a homeopathic practitioner, ND, that specializes in it. But I have found combination remedies. Some of you probably remember Dr. Bob, Dr. Van Horlick prescribing R14 when we were in school, if there's any of my colleagues from ND15s. But R14 I still use in practice, and I do find it quite helpful. It is a Dr. Reckeweg combination formula, and I usually use it for a combination of things like stress, anxiety, sleep, and it can be very helpful for grief as well. We find grief people often end up in pain because of the stress cycles, and depression is very common in these cycles too. And then physical medicines, manipulations, massage, physio. I just want these things to be done so that you're balancing the soft tissue and the bony. I don't want people to just have chiropractic adjustments if they're not thinking about helping the tissue around that to be settling down. Otherwise, you just kind of end up throwing things back out of place. Some supplement suggestions. Most of these are surrounding balancing inflammation, hormones. Estrogen matrix is something that I mentioned that helps to balance the estrogen ratios. I use Inflammatrix in my practice a lot. It is something that I have found helpful for a lot of different chronic inflammatory states. So this could be ranging from pain in a specific area, from sprains and strains, to headaches, problems with neck and shoulders. A lot of different reasons I would use this. Magnesium and B vitamins are important. And then Cyto has a couple of nice combination remedies, cramp matrix and relax matrix, to help with people that have more cramping pain, and then relax matrix. I actually use this in kids and people that have hard time swallowing supplements a lot, because it has a lot of things that help relax the nervous system, which is really important for modulating stress and decreasing that inflammation component. Other things that support the methylation pathways, ACEs plus zinc is a nice combination product. I always use combination products whenever possible because I like people to be on less things. And when you're thinking about different ingredients working synergistically, you can have lower amounts of different herbs so that you have a greater overall result with having less things in there. Helping the digestive tract to move properly and making sure that people are breaking down their fats and absorbing their fats. And then other things that can improve the nervous system, inflammation, and the functioning of the body. So a little summary here. Regulating hormones, implementing lifestyle changes, lowering inflammation and stress are really key to helping people get out of pain. Want a regular sleep schedule with ample sleep at a good time. Having people balance dietary unless you're actually allergic to something, most people do not need to be avoiding certain things 100% of the time. I think balancing, thinking about things like diet with the amount of stress that it would be creating is really important. So I don't want people to be super strict unless they're actually allergic to something. And then using things like low-dose naltrexone, supplementation, and other therapies whenever they are indicated. So last thing I'll leave you with here is a sugar challenge. I would like to challenge all of you to take out processed sugars and any extra sugars from your diet for the next 10 days. This helps to reset your sugar cycles and to help you have less sensitivity to sugar, meaning when you actually taste sugar after this, it'll be sweeter and you'll be less likely to consume it. So see how your body feels without it in the system. Thanks for sticking with us for this complex, but hopefully informational talk. Any questions? And I guess Frank has a quick pop in here.
I'm going to read a few questions here. What if DHEA is high to begin with in a male?
Sorry, it was the question when we'd see scenarios DHEA would be high?
DHEA is high to begin with in a male.
So DHEA and testosterone, they're slightly different levels that we would see in females versus males, but for the male reference ranges, we shouldn't see them high. They should still be towards the middle of the spectrum. If we were seeing them high for the male ranges, then that typically would indicate some sort of imbalance with the things above it. So either pregnenolone or things that are producing DHA, or something like in females, polycystic ovarian syndrome. In males, if you think of more tumors or other things that would be increasing DHA. So it should be in balance, it shouldn't be high, but in relation to females, it is higher.
Another question here, how high is a high DHEA? If it's just over normal levels, but not increased to a great degree, what would that point to? At what point would you be looking into tumors, and what would you investigate?
Yeah, so DHA we don't see high very often unless there's some reasons like prescriptions that would be playing a role there. But typically we will see it lower on lab work. There's been very few cases where I've seen DHA really high. But if we were to see it above the normal reference range, then that would be the point that I would start looking for tumors, just as a ruling out mechanism. So things like ultrasound of the pelvic region to see if there's anything going on with the gonads. If it was a female, definitely more ovarian. If it's a male, then testicular. Looking for other influencing factors like what's happening with pregnenolone upstream. So is pregnenolone high for some reason, then we might be thinking pituitary, other conditions that would be stimulating pregnenolone too much. And DHA is something that is quite helpful, but with any of the hormones, we don't want to see them too high, or they can create a lot of imbalance in other hormones. And usually when one hormone is too high, other ones will be suffering. They will have less resources drawn towards them. So we'll usually see things like estrogen downstream from it or low if we see something like DHA higher. Was that all the components there to the question, Frank?
Yeah. Another question, protein powders. What is a high quality versus low quality?
Yeah, so I worked for a company, Tallgrass, where that company distributes perfect protein. So I learned quite a bit about the quality of protein powders. Protein powders, when I think of certain companies that are geared towards bodybuilding, I don't usually support them as a place to buy protein powders from, because I do find contaminants and unnecessary ingredients are more common in that focus group. So even for a bodybuilder, I would often suggest protein powders that are produced by companies that I trust. So if someone's not sensitive to dairy, then having the Cytomatrix whey product would be good. Or if someone is sensitive to dairy, then I would usually gear them towards something like Perfect Protein. The reason I like protein powders like that is Perfect Protein is, so I don't work for this company any longer, but Perfect Protein has low amount of ingredients. They digest things in a way so they either ferment them or enzymatically break them down so that it is highly absorbable and less likely to cause any digestive difficulties. Plus, they do not include some things like peas, which can be more inflammatory and harder for people to digest. Yellow pea is better than green pea, but for protein powders, I usually will either send them to a supplement or a health food store. Like things in Victoria, I would send them to Lifestyles, Whole Foods, preferably a local place, but Whole Foods is a good spot typically to send people to. They will only typically sell higher quality things, so I trust what they're selling there as a result.
Okay, next question. What do you do when the estrogen becomes elevated, but progesterone is normal after bioidentical hormone therapy?
When progesterone's normal and estrogen's low, I don't see this very commonly. So this is one of those scenarios where I might give a little bit of estrogen without progesterone, but I would do some markers pretty quickly after initiating estrogen therapy to see what's happening with the other hormones. Usually because they're all coming from that precursor hormone pregnenolone, then we will unlikely see high amounts of progesterone and estrogen below because they're all going downstream. If you were seeing estrogen lower, definitely think about hormone replacement therapy. But if you're not using progesterone, then I would do it topically because that is the safest way. And you want to be protecting the cervix, the ovaries, the breast, any area, especially in a female. In males, you can use progesterone quite easily. There's quite a bit of research to suggest that progesterone is actually quite helpful for men, especially in scenarios where they're in pain. And there was one study with Iraq soldiers. It was done all on males that were veterans that had been in service after 2001. And the study found that progesterone was helpful in them for pain. They had lower experiences of pain after they initiated progesterone therapy. And estrogen is something I use probably a little less commonly in males, but look at the balance and no hormone because it's necessary for normal functioning. I would say no to when it comes to males or females, but looking at the balance is really important. So make sure you use topical if you're just using estrogen.
Okay. Next question. Could you please repeat the part about bile in vitamin D?
Bile impacting what, sorry?
Bile in vitamin D.
Vitamin D, yeah, you bet. So because bile is released when we eat fat-rich foods, so if you have a gallbladder that's not functioning properly, bile is not typically released when we're having fat-rich meals. And if you're missing a gallbladder, it's not released and any regular interval. It's more released as it is produced because the gallbladder is the storage vessel for bile. So we find that when the gallbladder is dysfunctioning or when it's absent, that we have a harder time breaking fats down. Now, this means fats are going to pass through the digestive tract more easily. We will sometimes see patients have steatorrhea or fat in their stool. Their stools are floating. That's a question I will usually ask, do your stools float or sink, so that I can help rule that out? Or do you see grease on the stool, or in the toilet bowl? Because without those fats being digested properly, we're going to have more difficulty getting those into the system. But because certain nutrients are fat soluble, vitamins A, E, D, and K, then we're going to have difficulty absorbing those fat soluble vitamins if we're not absorbing our fats from bile properly. So we need to make sure that we're supplementing with something like ox bile or other enzymes that help break down fats if a person doesn't have a gallbladder or if their gallbladder is not working properly.
Okay. Do you ever use Estrodot? It's an estradiol patch rather than the ice cream.
I do use Estrodot or similar patches, and the scenarios I would typically be using those in are patients that are more sensitive to estrogens. Sometimes after you initiate estrogen therapy, we would find that patients will start getting things like headaches, or they'll start getting things like hot flashes, and we shouldn't see this when the hormones are in balance, but some people are just more sensitive. So we often find that those estrogens need to be released at a slower rate, and that's when I would use patches, but also for convenience. Some people have a hard time rubbing on creams and they don't want to take things orally when that is safer. So the patch provides an alternative way to have a small amount of estrogen secreted over time. Sometimes we'll use that in combination with topical if indicated at certain times of the month, if a female's menstruating or if we need a little bit of extra.
Okay, next question. Progesterone for sleep. Do you still only RX it for 2 weeks of the cycle or throughout with differences in dosing for the luteal phase?
Yeah, so for progesterone, it really depends on the level of the patient. This is one reason why it's important to test the hormones before you initiate hormone therapy, is if a patient is really low, then I just want to increase that progesterone for a period of time before I worry about phasing it for a menstruating female. If someone is postmenopausal, then I don't worry about that biphasic amount of progesterone. There's some research to suggest that it can be helpful to have a postmenopausal have lower amounts in the first phase of the cycle and higher amounts in the second phase. And for postmenopausal, I don't typically worry about that because patients have more symptoms when you take them off of it. They don't sleep as well, they're not feeling as well, their energy and mood is lower. So I'd rather they feel better, and it's more protective for things like bones and other things too. So if you have them on estrogen, I want them on progesterone for similar amounts of time. If it's a menstruating female and we want to cycle it, then I typically will have a smaller amount for the first half of the menstrual cycle, day 1 being the first day of bleeding, and larger amounts for the second half of the cycle. The amount can vary a bit, but often it'll double the second half. So I might have them on 75 milligrams for the first half of the cycle and then 150 for the second half. So that we're able to balance the progesterone, but still have some throughout the whole cycle, which makes them feel better.
The next question, do you know of any non-ginger motility support products for gut motility?
Non-ginger related?
Yes.
Okay. To try to remember the exact ingredients in some of those other products, but I use a few products from Cytomatrix for digestion, as well as signature supplements. Signature supplements, if you have patients that are more sensitive or you're having a hard time finding particular products from them, they do make custom formulas. So they're a really good resource. They're from Canada. They have all of the basic ingredients that you would usually find for most supplement companies. But I believe GI motility doesn't have any in it. You might want to confirm that for me, Franck. And then things like GI's, what is it? Soothe is, that one is aloe. Sorry, I'm trying to remember this on the top of my head. Aloe. I do have those in some of the future slides. Let me just take a peek at them. But there are quite a few that Cyto has a couple, and then if you're having a hard time finding them, then Signature Supplements is another resource. Just pop back here and see if I wrote down the ingredients of these guys. So GI Soothe is DGL, marshmallow, and slippery elm. So that is one that doesn't have ginger. And then Cytozyme does have ginger rhizome in it. So I would use a different product that didn't have the ginger in it if that patient was sensitive and you wanted to use something that helps with fat digestion. I do use a couple of other products. I've used one from Designs for Health and a couple of other that are helpful for that too, but Signature is a great place to make those custom formulas if you need them.
Next question, can you speak to menstrual headaches and how this is connected to the link between pain and hormones?
Yeah, with menstrual headaches, there's two different scenarios that I've commonly seen. One is imbalance of the hormones. So estrogenic pictures are very common here, but something that's important to consider is estrogen normal and progesterone low, or is estrogen high and progesterone normal? Because these two scenarios you will treat quite differently. When estrogen is high, you want to get rid of it, but do it in a way that it is still staying somewhat continuous throughout the month. When estrogen is lower, then this is one scenario that I would often consider those ester dot patches. Different patches can provide more continuous amounts of estrogen, and those spikes are sometimes when we see the headaches occurring. And if progesterone is low and estrogen is normal, then we want to increase that progesterone. So it's helping with more of the anti-inflammatory effects and helping to regulate and make sure that the estrogen is being helpful. And then looking at the ratio of the estrogens also helps to determine if estrogens are playing a role. If there's a lot more of that 4-OHE1 metabolite, the more toxic one, then that could be something that will be creating oxidative damage and influencing headaches. So helping to detoxify and get that out of the system, usually liver support is necessary in those scenarios. So seeing spikes in estrogen and increases in estrogen would be the most common scenario, but having it out of balance with progesterone is another very common one too.
Next question, any opinion or experience with using Dutch Plus test?
Yeah,
awakening response test.
Yeah, so there's Dutch Plus, and then there's Dutch cycle mapping as well. The Dutch Plus adds the cortisol awakening curve, so a little bit of time before when the person would be waking up. And that is important when we feel like stress is one of the most important reasons why hormones would be dysregulated. Helps us to determine how much we need to focus on those areas. I do like that test a lot. It's just a little bit of an extra cost. So I do the Dutch Complete a little bit more often. In the Dutch cycling, they have the Dutch Cycle Plus, which also includes that cortisol awakening curve. So if you have a menstruating female that's having a lot of irregularities throughout the month, sometimes it's hard to determine when they'd be around day 19, which is typically the day for menstruating females we would test on. For males and non-menstruating females, we don't usually worry what day, or if it's an irregularly menstruating female, we can't quite catch their menstrual, then we just do it on a random day. But the Plus adds that cortisol awakening curve, which can be very helpful with stress.
And last question, any cause of high ferritin with normal CRP and ESR?
Yeah, so ferritin, because it can be influenced by infection and inflammation, if I see some of those inflammatory markers being higher, then I do like to run it with total iron so that it can help me to know if those levels are balanced. Total iron is an older marker for iron, but it still has clinical relevance, and it helps me to know if the total binding capacity and things like that look like they are good, or are they imbalanced? And if ferritin is truly high, then I'm looking for reasons why it might be contaminated, genetic conditions like hemochromatosis that would be causing it to be high. So we want to look at other markers and see if there's indications that it would be high for other reasons than iron being high itself. And then running it with total iron helps us to determine that.
So I think that's all the that's all the questions I can see.
Okay, if you have other questions, yeah, feel free to email me or Saito, and we can always answer those for you. Or if you have questions for me specifically, please feel free to email me. You can go to my website, drdella.ca, drll.ca. There's a contact form there, or just email me directly, contact@drdella.ca. And I also do consults if anyone needs help with anything or just some quick questions, no problem.
Thank you very much, Dr. Gary, for your amazing presentation tonight and for sharing your insights and on this topic. Very informative, very scientific, very clear, and beautifully presented. Thank you very much, Dr. Gary. This was excellent.
Thanks, everyone.